Good evening, and thank you so much for inviting me to participate in this fourth Abu Dhabi Multiple Sclerosis Congress. Just looking at the lineup, it seems to be getting bigger and better every year. So I've been asked to speak about women and MS, and there clearly is a close interplay between the female gender and MS. I mean, after all, the largest proportion of our patients are female, and there does seem to be a hormonal influence that plays out throughout life from puberty right up to menopause. But at no point in time is this more important than during pregnancy and lactation. So I will attempt to address this crucial topic in the management of women and MS. That's my disclosures. So back in 1998, the PRIMS study had attempted to look at the natural history of women who became pregnant with MS. And they had demonstrated that the average pre-pregnancy normal relapse rate was approximately 0.7 per year. And during pregnancy, this relapse rate dropped by about 70%, especially in the third trimester, to about 0.2. But then in the first 3 postpartum months, there was a sharp rebound by about 170%. But this gradually returned to normal to reach pre-pregnant levels after the first 3 months. And when they did a PRISMS extension study and followed the patients out to 2 years, it was clear that the relapse rate remained stable at pre-pregnancy levels, even in the subsequent year. And when they looked at disability over this period of time, it was clear that although there was some disability accrual, the rate at which it accrued did not accelerate because of the postpartum relapses. And in fact, the rate of accrual from pre-pregnancy throughout the whole period of time of follow-up remained approximately stable. So looking at the PRIMS and the PRIMS extension study, they identified 3 major predictors of relapses in the first 3 postpartum months. And these were the number of relapses in the pre-pregnancy year. So in fact, for every relapse in the pre-pregnancy year, you could expect a 1.7 times increased risk of relapse postpartum. Relapses during pregnancy, and for every relapse during pregnancy, you could expect a 1.8 times increased risk of relapse postpartum and a higher EDSS at time of onset of pregnancy. And these all significantly correlated with an increased risk of postpartum relapse, but the correlation was not direct. So you couldn't specifically identify who would relapse and who would not. But this was back in 1998. This was all in the pre-treatment era. So the question has arisen as to whether the pattern has remained the same, whether the numbers have changed. So last year in 2020, Ruth Dobson published a meta-analysis of 28 studies from 1994 to the present. And basically, they divided these studies into 3 timeframes. The blue line represents the studies published between 1994 and 2004. The brown line represents studies published between 2005 and 2009, and the green line represents studies published after 2009. And it's clear that over time, the baseline relapse rate has dropped. So whereas in PRIMS, the baseline relapse rate was about 0.7, now it has dropped to around 0.25. The pattern of some reduction in pregnancy has remained, and the pattern of increasing in the postpartum phase has also remained. But it is clear that in the recent years, the rebound that has been occurring postpartum has been minimal. And in fact, just last year, another study was published by Dr. Langer Gold, in which they retrospectively looked at data collected prospectively in the Kaiser Permanent medical records between 2008 and 2016. And they again show that there has been a drop in the baseline pre-pregnancy relapse rate to 0.37. The relapse rate, as expected, still drops during pregnancy, but postpartum, although there was a rise, it did not even reach pre-pregnancy levels. So there was no rebound as such. And in fact, only 22% of these women relapsed postpartum. And it is thought that there are multiple factors contributing to this. One is that these days MS is diagnosed much more early, partly because of more awareness and partly as well because of a change to the diagnostic criteria. So many women with MS actually have milder disease. More women are being treated, and maybe to some extent as well, more women are breastfeeding, and we will see later that this could also play a part. But also in the past few years, another problem emerged and another side of the coin has been reported. So basically, this was highlighted in a paper from Kuwait, where they looked at the pregnancies in the registry from 2010 to 2017. And basically 90% of these pregnancies occurred in women who had been treated with disease-modifying therapies and in whom these had been stopped for pregnancy. And contrary to what we had seen previously, 17.2% of these patients relapsed in pregnancy, and most occurred in the first and third trimesters. And then actually there was a bit of a drop postpartum to 13.7%. But it was clear that this was related to the fact that about a third each of the patients were actually on natalizumab or fingolimod before pregnancy. And when these were discontinued, the rebound activity was seen. And in the same issue, actually, an Italian group also reported on a cohort of MS patients who were pregnant and who had been treated with natalizumab pre-pregnancy. And you could see that the blue line represents the patients in whom natalizumab was discontinued for pregnancy. And you can see a sharp rise in relapses early in pregnancy and again early postpartum, and then return back to baseline. I will speak more about this later as well. And just in 2021, another Italian group reported on pregnancies in the Italian pregnancy data set between 2002 and 2008. And this time they looked at women with MS who became pregnant, and they matched them with women with MS who did not become pregnant. And the whole group was followed over approximately 6.5 years, a bit more, a bit less. And they were looking at disability progression. And it was noted that disability did occur in about 26.2% of patients. And in the pregnancy group, they looked at what was associated with the worsening disability, and they saw that relapses in the pre-pregnancy year were certainly associated with this increase in disability over this period of time, a higher baseline EDSS, a younger age at baseline, and a shorter period of time of exposure to disease-modifying therapy over this follow-up period. So now, based on PRIMS, we know that activity and relapses in the pre-pregnancy year increase the risk for postpartum relapses, but they also increase the risk of long-term disability over years of follow-up in the postpartum phase. So this highlights how really important it is to aim to plan for stability when planning a pregnancy. So this takes us to preconception planning. So previously, it was common to advise women not to start treatment until after they complete their family, but this could actually result in many years of delay. And we do know that neuroaxonal damage does start early on in relapsing remitting MS, and it accrues over time. And it is very probably, at least in part, responsible for the progressive disability that we see in the later phases. And it has also been shown that early intervention, early treatment with disease-modifying therapies does tend to reduce or at least delay long-term disability. So it is really important to start medication early. So we no longer really advise women to just wait. However, even when choosing that very first disease-modifying medication for however young the woman may be, it is very important to bear in mind that there could be eventual future pregnancies, even if they are not on the horizon imminently. So it is really important to discuss pregnancy issues and potential family planning very early on. First of all, it's amazing how many patients pick up myths along the way and how many seem to think that they can't have children or it's not safe to have children because they have MS. And it's really important to dispel these myths and to make it clear that actually, yes, MS is compatible with normal pregnancies, good outcomes, but there are certain parameters maybe to which they must stick. And they need to know that in their case, timing of pregnancy and planning the timing of pregnancy is very important. It's also important for them to understand that although they're on medication, the medications may actually be harmful to a potential fetus. So it's important for them to realize that medication will need to be discussed and planned. And in some cases, it would be stopped. In some cases, it will be continued. In some cases, it might be changed. And therefore, it's really important for them to understand that they really should discuss with their MS doctor before they decide to conceive. And in the past, it was relatively easy. So, we would tell everybody to just stop all disease-modifying therapy before conceiving. Very conservative washout periods were used, and then they would eventually restart a disease-modifying therapy sometime later after delivery. But actually, this is not a one-size-fits-all, and really, the plan should be much more individualized than this. And basically, the plan that we devise for each individual patient depends primarily on the severity of their MS, what medication they are taking at the moment, and to some extent also their own personal preference and fears. And the decision, therefore, whether to stop medication or whether to continue it or whether to change it needs a very in-depth discussion of the full pros and cons for them to understand why we are bringing up concerns, why we might want to change, and why we're not just saying stop medication and proceed. And as we've said before, it's really important for them to understand that it is important to aim for 1 year of stability before conceiving, and we're not just trying to delay capriciously. It's also important to make sure that they do actually comply with all the usual pre-pregnancy advice. They should be taking their folic acid, they should be maintaining very good levels of vitamin D, they shouldn't be smoking, they should be performing pelvic floor exercises, making sure that they're well conditioned, all of that. Now, so many women actually can safely discontinue treatment for pregnancy. And these are usually ladies who have mild disease and who are on a disease-modifying therapy which is not associated with rebound. And usually, if we do this, it's important to minimize the washout periods if planning to stop the medication. And if there are concerns, these days, we are also able to continue the injectables throughout pregnancy without undue concerns. So that is also another option. But who are the ones in whom we really have to worry? So basically, patients who have a higher disease activity in the 12 months pre-conception, but also who were active, before they were stabilized with the medication that they're on. Patients who have a higher disability before starting conception, pre-pregnancy. And of course, patients who are on a medication which is known to be associated with rebound on withdrawal, so patients who are on fingolimod or natalizumab, these all need extreme care and they need strategies to minimize and mitigate the risk. So what do we know about disease-modifying therapies in pregnancy? So this is a table that I borrowed from an excellent paper written by our local group of experts in the MENA region, many of whom are speaking at this conference, in fact. And this basically shows what the European Medicines Agency says about the medications and the labeling, and what the FDA says about the same medications. And there are some small differences. I don't have time to go into each of them in detail, but it's clear that interferons are the only ones which have the green light from the European Medicines Agency, where it is said that we can consider using them in pregnancy if clinically needed. And this is based on positive pregnancy outcomes in more than 1,000 patients, multiple registries. And I think Dr. Shitila spoke about this a couple of days ago. The Americans are a little bit more conservative and say to use them only if the benefits to the mother outweigh the risks to the fetus. For glatiramer acetate, the Americans say that there isn't enough human data to evaluate risk to fetus. And Europeans say that, well, basically because there isn't yet enough data, it's probably preferable to avoid just to be on the safe side. However, they may be used if benefit to mother outweighs risk to fetus. Teriflunomide is contraindicated, and in fact, if it's stopped, it will stay in the body up to 8 months, even up to 2 years. So if a woman is on it and wants to get pregnant, she should undergo accelerated elimination with cholestyramine or activated charcoal for 11 days. And then the blood level should be checked at least 2 weeks apart, and it needs to be low on both occasions. And they shouldn't attempt conception until 6 weeks after the first low level. With regards to Tecfidera, the Americans say it's completely contraindicated, but actually there is some indication that it probably is quite safe in pregnancy. There haven't yet been the 300 pregnancies required, but the European agency does say that it can be used in case benefit to mother outweighs risk to fetus. In fact, it has a short half-life, and we usually suggest stopping it with contraception. But in some cases, we also suggest stopping it with a positive pregnancy test. But in those cases, it is important to be clear that we are exposing the fetus in the first trimester to the medication, and this needs to be discussed with the mother. For the higher efficacy medications, for some it is quite clear. Fingolimod is definitely teratogenic, most likely siponimod the same. They must be stopped. Fingolimod would be stopped 2 months before conception, siponimod 10 days before. And of course, there is a problem with fingolimod, and we'll speak more about that later. For cladribine, conception is contraindicated for 6 months after the last dose. For alemtuzumab, it's contraindicated for 4 months after the last dose, but for some reason, the European agency does say that it could be used in pregnancy in case the risk to fetus is not outweighed by the benefit to the mother. Ocrelizumab, the American labeling says that you should not become pregnant for 6 months after the last dose. The Europeans say you should not become pregnant for 12 months after the last dose. But at the same time, the Europeans also say that it may be used in pregnancy if benefit to mother outweighs risk to fetus. And in fact, there have been a few reports of some fetuses who were exposed to ocrelizumab in pregnancy and with good outcomes. So it's still too early, but there may be some indication of safety there. And natalizumab, both the Americans and the Europeans now say that it may be used in pregnancy if the benefit to the mother outweighs the risk to the fetus. So what about natalizumab? So basically, classically, we always used to stop it 2 to 3 months before conception, but it's very clear that at least 40% of women treated with natalizumab rebound when they stop it. And if they stop it for pregnancy, they will rebound during pregnancy. And this tends to happen about 12 to 16 weeks after stopping it. And it can result in really severe disabling relapses. So we really need a strategy to prevent this. This is what is known about natalizumab. And because traditionally as well, sometimes patients have been asked to stop the medication with a positive pregnancy test, there have been a number of babies exposed in the first trimester. And based on various registries, basically, the consensus right now is that there is probably no increased risk of spontaneous abortions or fetal abnormalities. And whatever abnormalities have been seen have not shown a pattern, have not been specific. So it doesn't seem as though the medication is likely to be the cause. And this is supported by the fact that natalizumab actually does not cross the placenta in the first trimester, but it is actively transported in the second and third trimester. So in fact, if given late in pregnancy, it may result in hematologic problems in the newborn, especially thrombocytopenia or anemia, which may be a hemolytic anemia. But these are usually reversible over about 4 months. It's also thought that exposure throughout pregnancy may be associated with low birth weight and possibly with increased hospitalizations in the first year of life. So how can we approach natalizumab? So basically, the choices are, we can be semi-conservative and stop natalizumab at contraception, or we can be what they call semi-active and stop it with a positive pregnancy test. But in both cases, we know that the woman is exposed to the risk of rebound because there's a long wait ahead. Another option could be to just plan ahead and switch the patient to a depleter like ocrelizumab or cladribine well in advance of pregnancy, and then they will just have to wait that additional period of time required by the new medication. But sometimes you may not want to change, it may not be appropriate to change, the mother may not want to change. So another possibility is to continue natalizumab throughout pregnancy, usually stopping at about 30 to 34 weeks of gestation. So the UK group and an international consortium involving people from US, UK, Europe, Australia, and others, they both advise stopping at around 34 weeks of gestation. The MENA group advise stopping at about 30 weeks of gestation. And usually, if the natalizumab is continued during pregnancy, so as to minimize exposure of the fetus, the dosing intervals are usually increased to 6 to 8 weeks, more often 8 weeks than 6, probably. But then it is very important that if the last dose is given at around 30 to 34 weeks, it's very important to plan the next dose to be given no more than 8 to 12 weeks after that dose. So it really needs to be planned very soon after delivery. And if natalizumab is continued during pregnancy, then this should be considered a high-risk pregnancy. A pediatrician should be present at the delivery, and the baby's blood should be checked for a full blood count, lactate dehydrogenase, transaminases, and haptoglobin. So what about fingolimod? As we said, it's highly teratogenic and it must be stopped at least 2 months before conception. But of course, there is a significant risk of rebound on stopping. And this rebound occurs in about, it's not clear, but probably about 10 to 25% of patients who stop it. And it can occur as early as 4 to 6 weeks or as late as 4 months. And the severity of the activity ranges from mild and sometimes even only MRI activity to really severe fulminant refractory activity. So in fact, the UK consensus group, who initially had written guidelines with regards to managing pregnancy in MS in the UK, wrote an update a few months later in which they strongly advised that fingolimod should be avoided in women of childbearing age. But what are the options if a woman is on fingolimod? So if appropriate and if she's in agreement, you could consider switching to a cell depleter well in advance of pregnancy. And then, of course, they would have to wait the relevant waiting period. If it were ocrelizumab, if it were, the 6 months, if it were cladribine, the year and 4 months, whatever the medication requires. Sometimes it's not appropriate to switch or they don't want to switch. And sometimes we just stop and monitor. And very often in these patients, we do tend to bridge them, usually with interferons or glatiramer acetate. But actually, this is of questionable benefit because probably if a patient is going to rebound, they probably would rebound anyway, because really these medications can take from 6 weeks to 3 months to start to work. But still, they may help. So we usually do this. If a patient becomes pregnant while on fingolimod or, relapses, has this rebound shortly after having stopped the fingolimod during pregnancy, and relapse during pregnancy, then the relapses can be managed with pulse steroids. Plasma exchange may be used, or there have even been reports of rituximab use during pregnancy to manage a refractory relapse. And actually, rituximab does have indications of safety and is actually recommended in some other conditions in pregnancy, even in NMOSD. So in the peripartum phase, we usually advocate that having MS should not influence the mode of delivery or anesthesia or anything. That should all be governed purely by obstetric indications, except perhaps in the case of women with a really severe disability. If there is spasticity in labor, it can be managed by epidural analgesia or by diazepam, and a surveillance scan at about 6 weeks, especially in patients who choose not to start DMTs, may be useful. And it's good to monitor and watch for postpartum depression, which is common in MS. So about breastfeeding. So the effect of breastfeeding on postpartum relapses has been controversial because in the past, some studies showed protection, but some studies did not show this. So in 2020, a systematic review and meta-analysis of 24 studies was actually published by Dr. Crisco. And women who breastfed had a 37% lower odds of postpartum relapses compared to those who did not. And when they looked at the strongest studies and, throughout the ones with lots of heterogeneity and all of that, they found that actually there were 43% lower rate of postpartum relapses in those who breastfed versus not. And actually, the association of fewer relapses seems stronger in those who breastfed exclusively for at least 2 months. And there was another study in 2015 from a German group where actually, when they compared those who breastfed exclusively to those who breastfed only partially or did not breastfeed, the ones who breastfed exclusively had some protection, while the partial breastfeeding did not. And basically, in this study from Dr. Langer-Gould from 2020, they also looked at the influence of resumption of DMTs in the postpartum phase. And basically, if you look, these are the patients who resumed disease-modifying therapy in the first 2 months postpartum, and these are the ones who did not start disease-modifying therapy. If you look at the percent of relapse in the first 6 months, whether they started medication or not, the rate of relapse was the same. And if you look in the first 12 months, those who started disease-modifying therapy actually had an indication of relapsing more than those who did not. And in the German study, they looked at the ones who did not breastfeed exclusively. And again, in the ones who resumed therapy within the first 30 days, there was a 34.6 risk of relapse in the first 6 months, but those who did not start therapy relapsed in 44.8%. And actually, these were not considered to be a significant difference. So it was the same whether they started or not. And again, when they looked at the ones who breastfed exclusively versus the ones who started, so the ones who breastfed exclusively but did not start treatment compared to the ones who did start treatment within 30 days, the ones who breastfed exclusively had a lower risk of relapse. And this is a similar study in which patients with the dotted line started medication after 2 weeks at 2 weeks post delivery, whereas the others did not. And this is showing the time to first relapse. And actually, there is no real difference between the two at all. So it seems as though starting disease-modifying therapy early does not really influence the rate of the postpartum relapses. But the duration of this effect is unclear. Probably it is thought it lasts about 6 months. So it seems that women can breastfeed without putting themselves at increased risk of relapse versus if they did not breastfeed. And really, women should be encouraged to breastfeed exclusively for at least 2 months, but preferably for 6 months, which is in line with what the WHO advocates for general maternal and fetal health anyway, or rather baby health anyway. And there's no evidence that resumption of modest, so DMTs, so we're talking about the injectables, we're talking about Tecfidera, there's no evidence that in stable disease with low activity, starting these influences the relapse rate at all. And in fact, we should be strongly encouraging exclusive breastfeeding. And if they wish, they may use an injectable, which has been shown to be safe. Of course, patients with active disease, it's a different story, and disease-modifying therapy should be introduced early, no later than 2 to 4 weeks postpartum, preferably. And then in these people in whom disease-modifying therapy must be started, then the decision has to be taken whether to continue breastfeeding or to stop based on which medication they are taking. In a nutshell, the injectables are considered safe to breastfeed. The orals, teriflunomide, fingolimod, and dimethyl fumarate are not considered safe. Cladribine is considered safe 10 days after the last dose. With regards to the IV therapies, the monoclonal antibodies, breastfeeding officially is contraindicated, but most experts seem to think that it is probably safe because even though a little bit will enter the breast milk, it's probably not enough and is being given orally. So in conclusion, women with MS can have normal pregnancies with healthy babies, but this may need careful planning. Education and counseling around planning pregnancies should start early. And when selecting a disease-modifying therapy, always in a woman, always think of potential future pregnancies. Management should be individualized, and exclusive breastfeeding for at least 2, preferably 6 months, should be encouraged and supported. In more active disease, early resumption of disease-modifying therapy takes priority, but you should still encourage breastfeeding if the medication that we choose is compatible with this. So with that, I thank you for your attention. Thank my colleagues in the MS Center at Cleveland Clinic Abu Dhabi, and I'll be happy to take any questions.